Good evening, everyone, and welcome to our latest Back to Basics session. Thank you for joining us tonight. I hope you can hear me okay. Unfortunately, my screen is not working properly. But anyway, we'll just crack on as long as you can hear me. So tonight we are coming to you from Aberdeen as the Grampian branch are hosting tonight's session. My name is Kay Watt. I'm a podiatrist and a member of the branch. Part of my job is working in the Anchor Unit in Aberdeen Royal Infirmary. The Anchor Unit stands for Aberdeen and North Centre for Haematology, Oncology and Radiotherapy. It is the central hub for cancer and blood disorder treatments in the north of Scotland. This is where our speaker also works. I am delighted to welcome tonight Beverley Brown, an advanced nurse practitioner working in acute cancer care. Beverley is a very experienced nurse, having been working for over 12 years in cancer care. She helps to look after the patients receiving different types of systemic anti-cancer therapies, making sure they are fit for treatment and helping to manage any side effects caused by the treatment. So before I hand over to Beverley, I will just ask you, if you have any questions, please keep them to the end and put them in the chat and we can ask Beverley then. And I'll say good evening, Beverley. How are you?
Hello, I'm okay, thanks.
Good. I'm glad to see that your screen's working fine. Just ignore my one. So yeah, if you're ready to go, I'm looking forward to hearing what you have to say. Okay, thanks very much.
Okay, thanks, Kay. That was a lovely introduction. Hi, everyone. Good evening. So as Kay said, my name is Beverley Brown. I am an advanced nurse practitioner here in Aberdeen, working in cancer care. I have been qualified as a nurse since 2012. I started in oncology in 2015 and then commenced my advanced nurse practitioner training in 2017. So I have been around for a wee minute. I hope that everyone can understand my accent. So in Aberdeen here, our unit is comprised of an oncology unit and a haematology unit, so both inpatient wards, then combined with a day treatment area as well. So we treat a pretty vast number of patients on a daily basis, up to round about 70-ish patients on a daily basis in the day unit, and then both of the inpatient wards have sort of in the mid-20s inpatients, ranging from acute oncology admissions to elective admissions for anti-cancer therapies, to complications or new diagnosis of treatment or inpatient stays. So our job is primarily to look after two parts of the service. One part of the service is patients who are undergoing current treatment and who are having side effects of those treatment and need extra support. So they would call a dedicated cancer helpline number, which is a 24-hour helpline that we have here operating in Scotland. That would then be funneled into our service here at the hospital, and we would either contact patients back and help them by phone. Partly that's due to our geography here in the northeast of Scotland, that we cover a really big area miles wise, so we have to try and reduce the amount of times that we ask patients to travel in and out of potentially up to about an hour and a half drive to get to the hospital. But if we do need to see them, then we have an assessment unit here that we can assess and then treat side effects, toxicities from treatments, and then hopefully reduce their stays in hospital. The second part of our job is to then assess patients who are due to come in for treatment, and then treat, look at any toxicities that they might be having, and make sure that they're then fit to have their next course of treatment. So I'm just going to click through this. My slideshow wouldn't work there. I'm very sorry. I love technology. On a day-to-day basis, our teams work with various different teams throughout the hospital, from the surgical teams to the max fax teams, specialist nurses, dietitians, physios, occupational therapists, podiatrists, and our interventional radiology colleagues. So we have a pretty wide-ranging scope that we sort of take referrals in from, be that dietitians or the specialist nurses that are working with our patients on a sort of individualised tumour group basis. Our team cover all types of tumours. So we are what are known as generalised specialists, in that we are specialists in terms of cancer care, but we are generalists in terms of our oncology knowledge, and we're not working with one tumour group. So hopefully the idea is that no matter where you have a nurse practitioner working, the rough setup of the service would be similar to what I'm talking about here today. So if you are coming across cancer care in other areas of the UK, or in fact the world, the way that systems are set up are sort of going to be roughly the same as what it looks like here, in terms of how we assess patients and check that they are fit for treatment. So when treatment starts, that would be at the behest of an oncologist that a patient would meet with after having investigations in the diagnostic process, however they have come through that, be it surgery or imaging, radiology, however it is. The oncologist would then determine what that treatment is going to look like, which is then when our service would come into its own. So when the oncologist has determined what treatment that is going to look like, there may be a number of drugs involved in that. There is so many drugs now available within Scotland for oncology and haematology diagnosis that I attempted to find out how many there were currently available through the SMC, which is the Scottish Medicines Consortium, and I had to give up because I couldn't actually get that information in time. But there is continually new drugs being approved by the SMC and being available on the NHS, either widely available within the NHS or under an individual patient approval process. So it's perhaps not widely available, but our patients are able to gain access to it because they have been through previous treatments, if it's maybe not a initial diagnosis. So there's lots of different sort of complexities that go along with that process, which is why the oncologists would determine that, and sometimes that's done by using MDT processes out with our own area. So those drugs can comprise of chemotherapy, which is our traditional anti-cancer killing drugs, immunotherapy or targeted therapies, which are the newer style of drugs which are targeting particular cells or particular receptors or processes within cells to try and stop cancer cells from replicating. There are then hormone treatments and hormone therapies that go alongside and can help certain types of cancers from to prevent them from growing. We have stem cell transplants and CAR T cell transplants, which are transformational in terms of what they have made available to haematology patients. There are then a family of drugs called biphosphonates, which are helping to strengthen bones that have been affected by cancer, or to prevent them from being affected by cancer. And then there is radiotherapy in various forms that comes in as well. Alongside that regime, there may then also be supportive treatments that go alongside that. So whether that be that there is supportive measures put in place by dietitians, so whether that's feeding via an NG tube or by a PEG or a RIG tube, which is inserted through the abdomen. There's invasive devices that we use, like PICC lines, Hickman lines and ports to actually deliver the anti-cancer treatments through. And then there's then other devices such as syringe drivers, which can be used for delivering like anti-sickness medications to support patients, and then things like invasive drains that might be permanent or temporary to help patients that have maybe got excesses of fluids building up in their chest or in their abdomen that we can then drain off on a regular basis for comfort. So there is a lot that goes along with the treatment part. But once that treatment is decided on, our job would then be to explain that to the patient. So once they have their regime, we usually use this book. Hopefully you can see that on my camera. Not too fuzzy, but it is a treatment record book. So this record book, again, there will be similar record books, out with the UK, but this is the one that we use here in Aberdeen. It's produced by Cancer Research UK, and it is a record book that we give to patients so that they can they know exactly what regime they're having. We can write and in that alongside giving them other information about their particular treatment regime. And then what they can then do is use this to track the side effects of their treatment. So what happens is that usually the patients would come in for their treatment. They would then have this book filled out whilst they're in the ward. And then they would be directed to this symptom tracker that we've got, which can help with different side effects of treatment. There are, I think, certain side effects with chemotherapy, which are probably the most common or widely recognised, be that sort of rightly or wrongly, but I think it's probably the two that patients come in most worried about when they are seeing me. And one is always that a lot of patients have a phobia of nausea or being sick, and the other one is hair loss. So there are two sort of common misconceptions about chemo, and that is that probably these two things happen to every single type of patient with every single type of cancer treatment. And that's actually probably the most common misconception that I've heard as an oncology and hematology nurse. The truth is that actually that is not what happens, and a lot of SACT drugs, so anti-cancer drugs, will not cause hair loss at all. So lots of patients will come in and they are sometimes pleasantly surprised to find that actually that is not how things are going to go. The other thing is that a lot of patients think that they will automatically be sick as soon as they have a cancer treatment, which again is not true. It is definitely, it can be a side effect of some of the treatments, and sometimes that's a direct or indirect side effect. There are definitely some of the chemotherapy drugs that do cause nausea. The good thing nowadays versus even where we were 10 years ago when I first came into this sort of role and into oncology is that even with the medicine advancements that have come in the last 10 years or so, we're actually much better at looking after the side effects of treatments from cancer, anti-cancer drugs. The things that we use mean that actually we know more about how those things affect patients and know why they are being sick, and then can try to mitigate those things by having advanced nurse practitioners like myself monitoring patients as they're going through treatment to try and minimize those side effects. And as I always say to my patients, if I do have something that I think is going to make you feel sick, if I give you one anti-sickness medication and that's not working, there is always something else in my repertoire that I can then add into it or swap for something different. So yeah, that's probably to the biggest side effects that people are most worried about. There can be lots of other side effects with different treatments. Each treatment regime is slightly different from each other, so they will have a slightly different side effect profile. There are families of drugs that have similar profiles, but again, it's very difficult to explain each one of those in detail. What we would usually do is we would give our patients this book, which has the most common toxicities and most common side effects from anti-cancer drugs, but we would then also give them a sheet that has specific information for their specific regime. So if you are looking after a patient that is getting a particular drug, then the best thing you can do is see if you can get them to either bring this book in with or whichever book they have with them in to see you, to your appointment, so that you can double check if there is something that you think may give them a particular skin toxicity. There is a couple of resources that I have attached to the end of this presentation, so that hopefully you can use that as a useful sort of resource in the future to use to double check in terms of what treatments are, what you might expect, and if you think that something is a skin toxicity for a patient that you're maybe treating from a podiatry point of view, then it might help guide you in the right direction. So this book is generally used for sort of let's say a traditional chemotherapy approach. The immunotherapy drugs that we use as well nowadays are a wee bit different in that we know that they have a slightly different side effect profile from your traditional anti-cancer drugs and your traditional chemotherapies. The immunotherapy and the targeted treatments generally have less acute side effects. So you are going to have less things like vomiting or diarrhea or the extreme fatigue that's sometimes associated with some chemotherapies. But what it can do is it can sometimes cause some fairly inflammatory skin toxicities. One of the most common ones is probably an acneiform rash that some of the immunotherapies can cause. That is usually flagged up quite early on because we are continually monitoring patients. So it isn't something that patients should be unaware of. But just in case, again, using the resources that I can give you at the end of the presentation, you might find useful just if someone turns up with something like that. The other things that immunotherapy can be known for is the way that immunotherapies work on your body is that what it is trying to do is it's trying to stimulate your immune system to mount a response against the cancer cells. Sometimes that is by blocking receptors that are allowing the cancer cells to replicate and to multiply and to grow. So what it's doing is it's using your immune system to build a response against that. Sometimes with that, your immune system can be overstimulated. And what that then leads to is inflammation in areas of the body that you're not expecting. So sometimes that can be, like I say, in the form of a rash. It can sometimes be in the form of playing havoc with some of your other systems in your body. So your thyroid function, your adrenal gland, sometimes your pancreas, your liver, your kidneys. Generally speaking, we usually see changes in patients' blood results as we're doing our monitoring, so that we can sometimes identify any toxicities before the patient's actually physically feeling unwell or aware of anything that's untoward that's going on. sometimes those toxicities come out through digestive systems or in your respiratory system. So sometimes it can cause inflammation in the lungs and lead to pneumonitis type infections. And sometimes through the digestive system, it may cause things like an immunotherapy-induced colitis. So that is all of those things together sort of make up why we have things like the cancer helpline that we've got here in Scotland, so that patients can access help 24 hours a day, so that if there is a toxicity or a side effect that is cropping up quite quickly, then they can get help, and we know which drugs the patients are on, and then we can hopefully take effect and take action quite quickly to reduce that side effect. So a little bit more about skin toxicities in terms of podiatry and thinking about skin issues that you might see. Probably the most common ones that we see as advanced nurse practitioners are some of the things that you see here in the pictures. So the hacks on the hands, and then I'm not sure that picture's come out very well actually when I've added it to the PowerPoint, but it's something called palmar-plantar erythema, which can affect the soles of your feet and the palms of your hands if you're on particular drugs from us. What that means is that when you are started on these drugs, there is usually a progressive worsening of dryness of your palms of your hands, soles of your feet, which can then lead to blisters or cracking of the skin, can lead to hacks that's seen there in the photo on the left, and can cause quite a lot of pain, a lot of heat in your hands, feeling like there's a burning sensation. It can affect patients and how they walk. And at worst case scenario, if patients are underreporting or not reporting symptoms to us, it can lead to necrosis in your skin tissues on your hands, probably more particularly on your feet, because patients tend to hide their feet underneath socks and shoes and not tell us about it. But hopefully, with our podiatrist community, it is a good thing to be able to recognise these situations as they arise, and then refer them back into the hospital so that we can hopefully help our patients. So with the palmar-plantar erythema, there are some common culprits of drugs that are renowned for, renowned, that's a terrible thing to say, but very well known for causing the types of problems that I've seen here in that previous photos. So families of drugs called taxanes, so docetaxel and paclitaxel, and then the anti-metabolites, so capecitabine and fulfusor pumps, or 5-FU, which is a fluorouracil-based drug, are very, very common for causing palmar-plantar erythema. The taxanes are also pretty, they quite often cause parocnia or oncholysis around the nail beds, and quite often patients may lose a toenail, lose a fingernail. Again, it is something that we can treat if it's highlighted to us. I think a lot of patients are still under the impression that it's just something that may happen, and that they just have to put up with it. But we try to encourage patients to report to us any treatments and any treatments that are causing that for them. So again, if you do see any patients that are having these types of problems that they've maybe not reported into their nurses or their oncology teams that are looking after them, then I would definitely encourage them to do so, because there are sometimes other things that we can do to reduce the effects of it. Can't always stop it from happening, because some patients are just more prone to it than others, but it's definitely something to encourage reporting of. So with these types of treatments and with your problems such as palmar-plantar, the oncholysis parotchnia, and then also the one that I have not mentioned, which, sorry, gross mistake there, but a lot of patients have peripheral sensory neuropathy, which is progressively worsening through their treatment, and they may seek help through podiatry services to try and help with that and try and minimise pain and things in their feet. But again, it is something that we need to encourage to report into ourselves so that we can modify the treatment if we need to. Cancer treatments are generally based on a body surface area calculation, which means that if patients lose weight through treatment or gain weight, then we can adjust the treatment to better suit their frame. What that also means is that just because it is a body surface area calculation, it's not always accurate for what patients can tolerate. If they are perhaps a little bit frailer or possibly a little bit older, and that is not, it's a sweeping generalization there, but there are lots of different reasons why patients might not be able to tolerate their 100% dose. With that in mind, we will sometimes then modify the dose that we are giving to patients, and that's depending on how severe their side effects are, in terms of if it's neuropathy that is the issue, or palmar-plantar, or any other toxicity that they're having. And that is the goal of us trying to pre-assess patients prior to them having treatment, so that we can try and make these modifications as we go along. It also then depends on the goal of treatment for that patient. So in some cases, our consultants will deem that we need to attempt to be relatively aggressive in our approach to treatment. So they may be more reluctant to reduce a dose if the treatment efficiency may be affected, and if we're aiming for a curative intent at the end of that treatment. However, if we are treating with a non-curative intent, so perhaps someone who is a palliative patient, which means that it is a long-term but more of a chronic situation, rather than we are aiming to cure, then we may tweak the dose downwards by a certain percentage to then be able to continue giving that at the regular interval that it's supposed to get. When I mention palliative, curative, non-curative, there are a lot of terms that are mentioned within cancer treatment. Palliative probably used to be a term that was used as quite an end stage situation for patients. However, nowadays it is generally used in a broader non-curative sense, in that we know that there is still lots of options that we have for patients, especially with such a wide range of drugs that we've got nowadays, but it just means that we're not going to be able to cure our patient. We don't tend to talk about end stages of cancer and as a terminal diagnosis until we are looking at the very end stages of a patient's life and there are no more treatment options available to us. So just so you know, I think palliative probably used to be used as a fairly short-term outlook for a patient, but that's certainly not the case nowadays. I think this is almost me at the end. So other considerations from a podiatry point of view to take into account when you're looking after patients. If you have a haematology patient, they are going to be at a slightly greater risk of bleeding, generally speaking, because of their conditions. They tend to have lower levels of platelets, lower levels of red blood cells, which means that if you are doing any interventions with them, they may be at risk of bleeding a little bit more and needing a little bit more pressure applied. if there's any questions, I would maybe just double check what their counts are before doing anything. This also applies to some oncology patients as well. And bearing in mind that a lot of our patients are also anticoagulated, either as a preventative reason for during treatment, or possibly because they've developed a blood clot or something during their treatment as well. There is an added infection risk for our patients. I think it's fairly widely known that if you are having anti-cancer treatments, that there is an infection risk for our patients. Sometimes that is worse with some treatments than others. Chemotherapies tend to be a little bit more immunosuppressive than some of the targeted therapies or immunotherapies. And sometimes it is a case of there is a bit of a peak and trough with their treatments. So we talk about patients being in nadir, which is when their bloods are at their lowest, which usually speaking is about 7 days after you've had a chemotherapy treatment, and that lasts up to about, roughly speaking, day 14. But if there's any questions or anything that you're not sure of, then it's probably best to double check with the oncology team or hematology team. So I think this has got a few links on it here that has just got some of the things that I mentioned, and also just a really good source to look up if for names of treatments. If a patient comes in and tells you that they're on a particular drug, then these sources are excellent at having most of the useful information. The Cancer Research UK and the immunotherapy guidance from Clatterbridge Centre are pretty good at having most of the treatments that are available in the UK at the moment. So I think that is me all finished. Hoping if you've got any questions, then you can pop them into the chat.
Hi, Kay. Sorry, if you just need to unmute yourself and just make sure you've muted the back. I think that's all that's happened. I'm sorry, guys. We've just been having a couple of problems with Kay's internet connection. Must be being so far up north. So we'll just try and get that sorted out. 1 second. Bev, that was fabulous. Thank you so much for, I think, actually a really useful insight there to the process that happens in the background. I think sometimes, we get a little bits of it from patients. We may get little touches. So thank you so much. Let's just see. I see Kay back there. Kay, is that you? Oh, you need to unmute yourself there, Kay. So there's a little mute button down in the bottom left-hand corner on the screen there. There you go. Sorry about this. There's always the lovely fun bits of technical. Kay, do you have your laptop on as well? If you just make sure you mute your laptop as well, then that means we should only have the one sound. Oops. Okay. Okay. Do you have the laptop on as well? Okay. We'll go for a moment there, and we'll come back. If you do have any questions, guys, please do pop them into the comments section. There we go. That's me up there. Sorry. I shall jump in while Kay's trying to get sorted there. So I do apologize. Before we do, though, go to questions, Bev, just a couple of little markers there for it. For those of you that haven't done yet, Grampian Branch has done a great job of organising this, and they are in the process of organising the 2027 Scottish Conference. So if you are looking for tickets or interested in joining our fabulous hosts up in an amazing venue in Aberdeen for what I'm sure will be another fabulous Scottish Conference, then do check out the Glasgow RCOP acute.org.uk page. Just in the background, we also have a CPR update that's running every other month. We had our last one last Thursday, so the next one is July. So again, you can check that page out if you need a CPR update. Some of you may not be catching up with us because you're taking part in a POMS-S update with Dr. Jean Mooney, which is in its 4th of 5 sessions. That's on tonight. But if you are needing a POMS update, you can catch up by signing up and catching the videos in the Facebook section. And last but not least, we have a little bit of an announcement which we did make at the Scottish Conference 2 weekends ago. But for those of you that haven't yet heard about it, here's a little bit a message from 2 welcome names from the podiatric world.
Jill, what are you doing in September?
Oh, I think I'm going to Stirling on the 26th or the 27th. Are you going to be there as well?
Yeah.
That's amazing. Why are you going?
Well, there's this amazing little thing called 1,000 Small Steps, which is designed to help podiatrists and podiatry students to really talk about what they do in their profession from a really passionate place, and to give them the skills not only to stand up in front of groups or to maybe go on video and talk about it, but also then to market it afterwards. And I understand that you're like a marketing expert that's going to help them with that.
Well, so you and I know, because I know your story, like we both came into the profession because we spoke to our local podiatrists, right?
Absolutely, yeah.
And
absolutely.
which
is how it happens. Which is how it happens.
Exactly. So if we could imagine lots of podiatrists giving 1,000 presentations across the country, and we could skill them up at a free workshop in September in Stirling, can you imagine the impact that would have?
That would be amazing. And the great thing about it is it's free, because we know that podiatrists and students like free stuff, and lunch is provided as well, which is really cool. And there's probably going to be some stuff going on afterwards, which is always good. But the great thing is, and this is my favorite word. Well, it's not my favorite word. It's one of my favorite words. Community, because we work as practitioners on our own. So coming together as a community to support each other is huge. So you don't get to do this on your own. It's going to be brilliant.
It's a great phrase. People come for the information and stay for the community. And I think that's exactly what's going to happen. We're going to build a community of 1,000 Small Steps practitioners who are going to be pulling together, supporting each other, and doing an amazing job of talking about podiatry and telling podiatry stories.
And somewhere on this post there will be, it sounds like the marketing bit, doesn't it? Somewhere on this post there will be a link to sign up. It's free. It's free. Come along, sign up, come and join us. We would love to see you in Stirling.
Fantastic. We're really excited to be launching this, and this is the first time we've announced it outside of the Scottish Conference. So if you are interested, we will be in Stirling for the last weekend in September, and you can find out more details on the website. Bev, thank you so much for your patience. We're going to just try and see if we can bring Kay back again. Now, this video's been a bit sticky, but hopefully the sound is there. So we're going to just try popping this on now. Hi, Kay, is that you back? Just going to get you to unmute again.
Right, can you hear me now?
We can. Your video is sticky, but I shall hand back over to your capable hand.
Okay, well, thank you, Michael, for doing all the announcements there. And thank you so much, Beverley. That was really good. I really enjoyed that. Yes, no, you did really well. And just confirms it's such a complex thing to be going through at such a time in your life. It's such a stressful time for the patients. And I find myself, when I've got them, they've got such complex histories and all the drugs that they're using, and you can't even say them, never mind understand all what they're going through. So yeah, as you were saying, a lot of the side effects that I see is like the nail infections and stuff. Like people have never had any problems with their feet before, suddenly have, well, toenail infections is a big one, and that's. I find that's fairly straightforward to treat because you just, but it's people, it's just reassurance, and it's good that, I can be there for them.
Absolutely.
So that's fine. But one thing that I do find harder to deal with is the peripheral neuropathy, because that's quite a hard thing for them to deal with, and it can really bring them down.
Yeah.
They can get quite depressed with it. So I just wonder, do you have any tips for how to deal with neuropathy?
Yeah, so there's a few things that we can try. So I would definitely, if any podiatrist does come across anyone that is having neuropathy whilst they are having their treatment, definitely encourage them to report it to us, because it is something that we try to pick up as patients are going through treatment, and it's something that we always quite specifically ask about. However, you do sometimes get the patients that underreport it. The earlier they can report it into us, then actually the more effectively we can then deal with it, because we can use things like menthol creams to help with sort of like cooling sensation for feet. We'd sometimes suggest neuropathy socks, which you can buy, which are similar to sort of compression type stockings, but can sort of go to different like acupressure points on the feet, which anecdotally patients tell us can be quite helpful.
Where did they get them from?
So you can buy them online if you like literally good old Amazon. But if you do look up neuropathy socks, it is a thing.
That's good to know, because I've not heard of that, so that's something to add.
And, some of these things are actually like just things that have been developed over the years, and actually it's our patients that tell us that it's helped. So it's not always something that's come from sort of like a professional side of things.
It's
more
not clinical
evidence. But we know that it does actually help with patients. The other things that if it does depend on the grading of it as well. I know I can see Sandy had said sort of particularly like post chemotherapy neuropathy, and so generally we would say with chemotherapy we sometimes see neuropathy not really improving sort of in that acute, like even 3-month period sort of after chemo. It doesn't really make, it doesn't change much if you've had a fairly significant neuropathy. But sometimes you will then get an improvement from about up to 6 months, up to even a year after treatment. It can still improve. But if you're still having significant sort of issues in terms of pain, and if that's debilitating, it's really being quite restrictive to your mobility and things, then we would generally ask your GP to become involved. And in terms of, there might be analgesia that is available to you. So you're sort of more like nerve type painkillers. So your gabapentins, pregabalin, amitriptyline, those types of painkillers is what the GPs sometimes look to try and help with that that neuropathy sensation, which can be really, really not very pleasant, can stop you sleeping, can really sort of interrupt your quality of life. The other thing that patients report into us from just a sort of symptom relief point of view is sometimes reflexology and acupuncture is the other thing that can sometimes be helpful. It depends. A lot of our patients find that actually you are not their favourite person in the world because they don't like people touching their feet at all. If you've got very tickly feet, then that's probably not the one for you. But yeah, that's the other thing that patients sometimes find helpful.
Well, that's good to know, because sometimes you're not sure where to refer them to. Another thing, and a lot of the drugs you're saying, obviously we treat patients undergoing chemotherapy as high-risk patients, a bit like our diabetics who get similar symptoms, peripheral neuropathy. Yeah. And another thing that we sometimes suggest is capsicum cream.
I have heard of it. Yes.
That's not something you particularly.
No, so it's not something that I've really had probably that much experience with, if I'm perfectly honest. I have heard of it, but I don't have any even anecdotes to say whether someone has said good or bad. But certainly I would say it's probably not I think sometimes as well, it's one of those things that actually anything is worth a try if you're in that amount of significant pain, and it's not going to do any harm. Then yes, it's something that you could try. our it's like a mini advert here, Kay, this is terrible, but like because you work with Friends of Anchor, we are so lucky that they give us our little patient packs that we can dish out to patients. And generally, as a sort of normal emollient, I will put this here, but this one is one that we always give to our patients as part of their patient pack. It's called Mugu, who have their very own cancer range. So they've literally got a cancer range on their website, and it goes from like shampoos, all these different things that are available, and then just high content urea from a general moisturization point of view is where we would sort of steer our patients towards, just at the onset of treatment. Do this. I generally say to patients, I know it's not, like, especially like, not being completely sexist, but sometimes men, and maybe men in the Northeast that are of a certain age, the idea of moisturizing themselves on a regular basis is not something that they would have ever done, because I'm like, put some moisturizer on, especially hands and feet, because they get so dry through chemo.
I agree with you. You're seeing the same as us. Encouraging men to moisturize their feet. No, they're not keen. Brilliant. What else was I going to ask? I was reading again with peripheral neuropathy, like they put the cold caps on people's heads to reduce the
chirotherapy.
Yes,
for your hands and feet. Yes.
Is that a thing, or is that?
So I didn't mention it. Yes, it definitely is a thing. So chirotherapy you will find in some centres in the UK. It depends on where your listeners are today, but some centres offer it and have chirotherapy, very similar to, like you say, the cold caps that go on your head. It's sort of booties, and you can get them for your hands as well. It's not something that we have here in Aberdeen. The evidence base for it is not quite so widely developed as scalp cooling. Probably it's a bit of a newer treatment, and I guess it's the difficulty of actually having an effective chirotherapy that is quite portable for patients. So there is obviously newer things on the market, like you say. You've sort of seen the booties that you can get, and then you can get ones for your hands as well. The difficulty sometimes is if we're putting a cannula in the back of someone's hand, then it's quite tricky to then, we've got to warm you up and make sure that we can get access to you before we then try and cool you down. So it's the sort of balance of getting those bits right. But I have had some patients use chirotherapy, and even I've had the odd patient come in with just like ice packs from home, just like the wee box that you get for your freezer, and then sit with their feet on ice blocks, like whilst they're having their treatment.
That's okay.
I'm not sure if I've ever seen anyone actually continue that through all the way through, like X amount of 6 sessions or 10 sessions of chemotherapy that they're getting. And I don't know if that is purely because of the location that we live in. Sometimes it can be quite cold in the northeast of Scotland. So sometimes actually just the comfort level of doing that whilst you're also sitting in a ward and actually physically making yourself very cold when you're a bit uncomfortable anyway, is not, it's not always something that patients really want to put themselves through.
And how long does it take for the treatment? If they were sitting with something cold, how long is it like an hour? Is it 4 hours or?
So it can vary depending on which regime you're having. So some of our treatments that patients would scalp cool for, sometimes they've got the scalp cooler on for almost 7 hours of the day. So it is a very long period of time sometimes. So it is, it's hard to then sit with your, your feet essentially in a block of ice for that long period of time.
And especially when it's not maybe proven to be effective. But it's maybe something to consider. So
absolutely.
Excellent. So Sandy, he has another question. He said, is there a foot screening program within Anchor Unit, or is it treatment only? Well, I can maybe answer that. There's not really a foot screening program, but it's basically any staff or patients can refer themselves to the podiatrist, and there's they are entitled to assessment and treatment with myself. There's no limitation really, but we tend to stick to people that are undergoing treatment that can get podiatry. But there's no restrictions to, they can just refer themselves. They don't have to have a referral criteria as such. It's just their name and come along. Because I am part, luckily for us in Aberdeen, I'm part of the wellbeing team. So it's, you know, sometimes it's just to make them feel better rather than actual problems as well. So yeah, we're very lucky that way. Yes.
I think also, I guess from our point of view as well, Kay, like again, foot screening programme is probably quite a formalised way of saying it. We would screen patients' feet as part of their general pre-assessment.
Yes.
But I do rely on patients being truth tellers and letting me know if there are problems. So I wouldn't necessarily, when you talk about like a diabetic foot screening, it's part of a diabetic foot screening that you would physically remove patients' shoes and socks every time you see them at their annual review. Whereas I don't do that as part of my assessment of a patient. I would just rely on them to tell me the truth, Sandy. So hope that helps.
Yeah, brilliant. Thanks for clarifying. Yes, yeah. But yeah, that's fine. So I think, is there any other questions? We're also wondering, another thing that comes up, because, you know, with the toenail infections and stuff, I would always, you know, one of our treatments would be like nail surgery. But, you know, we wouldn't do that obviously when they're getting treatment. But how long would you wait before that something like that, they might be suitable for something like that? Or you just have to keep an eye on their bloods and go by the oncologist?
Yeah, so generally speaking, when we're talking about safety for procedures after chemotherapy, technically speaking, chemotherapy, you know, we would expect bloods to return to normal about 3 weeks after you've had chemotherapy.
Okay.
We would then expect chemotherapy to be out of your system by 6 weeks. I am only talking about chemotherapy here as opposed to targeted treatments or immunotherapies, because they stay in your system for much, much longer. But chemotherapies that are like acutely immunosuppressive, we're talking about 3 weeks, roughly speaking, for bloods to come back up to acceptable standards, 6 weeks for then chemotherapy to be out of your system. So if we were planning, even if it's nail surgery or a different kind of surgery, then sometimes roughly speaking 4 weeks after their last treatment is where we would that's our goal as such. So
that's good to know. Yeah,
that's what we do.
To have a bit of a timeline. Okay, so we've got a last question here. It says, is there a foot screening programme within the anchor unit, or is it treatment only?
Was that the same question? Was that Sandy's?
That is the same question.
Oh, that is. It's come up twice. That's okay.
Yeah, it has come up twice. Sorry. Well, I think we've answered that one already. Yes, there's, I screen a patient like you'd screen any patient. So it's very similar to what you would do with a diabetic or any high risk patient. So yeah, they are screened and then they get treatment that is suitable after that. Okay, so I think that's our nearly time up, Beverley. Okay. That has been great. I have really enjoyed tonight and hearing from you and hearing about all the complex treatments that, chemo, immunotherapy, targeted therapies and all the side effects. So yeah, it's reassuring. So I think I will watch this back later and get a bit more from it. And it's good to know that you're there to, for information and signposting, and your links at the end were also helpful for everyone. So it just leaves for me to say thank you so much for joining us tonight, Beverley. That's been really good. I'm sure we've all got a lot from that. I also want to say thank you again for the Grampian branch for hosting. Apologise for our lack of signal, but I think we've got there. As long as we could hear you, Beverley, that's the main thing. And thank you to everyone out there for joining us tonight and for providing us with some questions. And hopefully we'll see you all at the next one. Okay, right. Thanks just now. Okay.
Bye.
Good night. Bye. Bye.